Hey, good morning. This is Steve Stites, the Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dol Simons Family Studio. Delighted to be back with you on this Friday, exactly 1 week before Christmas. It feels somehow good to say. But Hawkeye, how good are the numbers today?
You know, they are better. They aren't as good as they could be. I think the numbers for COVID-19 hospitalizations are like limbo and golf scores. The lower, the better.
Yes, they are.
So we have trended down, but we need to trend down further. So keep doing the masking, distancing, not meeting in groups, especially as we're getting into the weekend now and Christmas week. So, but 78 active infections in the hospital, which is a lot better.
That's better.
35 of those in the ICU, so that proportion of ICU patients is better as well.
That's
and
better.
26 on the ventilator. We do have 71 who are in that recovered phase with 8 still on the ventilator, so about 149 patients total. Unfortunately, we did have 2 deaths over the last 24 hours as well. Same thing with Hays. They had 2 deaths over the last 24 hours. They have 25 COVID infections with 21 active and 4 in that recovery period.
You know, those numbers feel better to us because we were up around 160, but they're still really high.
Yeah.
And I know that is one of our biggest concerns. We don't want people to get cocky. We don't want people to get overconfident just because the vaccine's on the way. We don't have nearly enough people vaccinated yet. We got a long, that means very long, ways to go in order to get people vaccinated. And that's what's going to help keep us safe. So in the meantime, remember, when it comes to COVID, strong offense, and the strong defense. And the strong defense is best represented here today by our colleague Amanda Gartner, who's back with us to help answer questions. She's our Director of Quality and Safety, does a great job of keeping us all safe. And of course, Hawkeye. And also joining us is David Wild, VP of Performance Improvement. He's going to take us, we're going to take a look back on some of the early days of COVID-19 and share some numbers that keep us up at night a little bit. So Dr. Wild, let's talk about some of that.
Yeah, good morning. Well, you know, 150 is definitely better than 160, but it's not necessarily a great number when we look at the impact on our hospital. And yeah, if you take a second and think about what's happening even right now this week, Kansas is in the top 10 states in the worst way, not the best way, but top 10 states for the highest number of cases per million population this week and highest number of deaths per million per population this week. So we're definitely not over the hump here. While being stable at around 150 is a good thing, I'd much rather be at a lower number than that. To sort of put this all in perspective, we just brought 3 things this morning. I'm sure this will flavor the conversation for the rest of the morning, but this is a look at what's happened to date here. So the impact of COVID-19 on our hospital to date. And this is actually through yesterday, so through the 17th. 1,727 admissions. The average age of those needing to be admitted to the hospital remains steady at about 57. Of those 1,727 admissions, 454 hit the ICU. So that 35 number that Dana talked about this morning, you can sort of put in perspective compared to the overall number since the beginning of time. And 270 of those 1,727 needed mechanical ventilatory support. Those patients stay an average of 7.4 days. So that's a lot of hospital days, just multiplying 1,700 and change by 7.5. And of those patients that got admitted, 130 of them have died while in the hospital. Many more have died either on hospice or after being discharged. So the total impact of deaths is actually higher, but that's the number of patients who've died in the hospital so far. Though the average age of those that have died in the hospital since the beginning, since March, remains also fairly stable at around 67. That's crept up just a little from 65 over the past maybe 2 or 3 weeks. And you can see that the average length of stay, the amount of time that those that die stay in the hospital, is approaching double that 13.3 days. So a significantly longer hospital stay than those who recover and go home. And you know that tells a story. That's sort of the overall impact. But when we talk about what's happening right now and how we can't let our guard down, and our good defense remains very, very, very important over the next many months, probably for the majority of the population, Here's a look at the number of admissions by month for COVID-19 to our hospital. So you can see March, April, May, June, we stayed relatively stable, right, as we understood what was happening in the community and had probably more restrictions in place as far as movement around our community and interaction with each other. And then you can see as things started to reopen, we picked up in July and August, and September was maybe a little better. We started to see things in October, and then look at November. We more than doubled from October, which was our previous high. So 451 admissions to the hospital in the month of November. And that doesn't mean those patients were discharged in that time. They may have been discharged in December. And so we're just looking at how many people hit the doors needing to be hospitalized in each of these months. So I mentioned these were data points that were pulled yesterday, which means that they were admissions reported through the 16th of December. So just over half of the month of December, we already had 247 admissions in the month of December. And if that pattern, the slope of that line were to continue, we will actually have another record month in December. So we're anticipating that number will hit or exceed 500 before the end of the month, based on all signs that we see across the community. So things definitely are not better or even significantly better, as we may have heard a few people say outside of the hospital in the past few days. No doubt there is an impact of all of the things that our community is doing, the mitigation efforts that are in place, whether they be public health orders or even more importantly, the actions of individuals are having an impact. We're not rapidly doubling, for example, like we did from October to November. So there is good news, but we're definitely not over the hump. The more sobering number, though, is probably on the next slide. So a lot going on here, and I'm going to ask you to pay attention to the blue colored bars. Those are deaths that occur in the hospital and hospitalized patients here in our hospital every month. The sort of red color is deaths that occur in the emergency room, so the patients are not admitted to the hospital yet. And then that teal color or green is anyone who was admitted and died after an admission, either in a long-term care facility or in hospice or at home, if we were made aware of it. So sometimes we don't know those things. Many times we do, as we hear from families or otherwise. But the blue bar is the bar I want you to pay attention to. So you can see how the month of November was significantly higher than any other month, 30 deaths in the hospital. December, though, however, we're already at 32. So just over halfway through the month of December, we've seen more deaths than our previous high. And unfortunately, we expect that number to increase as well as we approach the end of the month and the end of the year. This is sort of the big picture reinforcement that the things we've been worried about and the things we've been talking about, that hospitalizations follow cases by several weeks and deaths follow hospitalizations by several weeks. We're really seeing right now the impact of things, at least in the cases of deaths, from a month ago. And that doesn't even get us to Thanksgiving yet. So again, it's sort of the message that we're not over this yet, despite the fact that we are all working very, very hard to remain solid on our defense and focusing, of course, on the benefit of the offense that we now have very differently than we did a week ago. So, Steve?
Thanks, David. It's kind of the Michelle Obama paradox. As the virus tries to go high, we need to go low. And we can do that by following the rules of infection control. Let's see what questions we have from reporters out there.
Hi, good morning. Cody Holyoke, KMBC 9 News.
Cody.
Hey, happy Friday. You're very festive today.
Well, thank you. How about that vest, huh? Wait till you see my ugly Grinch sweater next Christmas.
He is so glad someone noticed. Thank you for noticing.
I know.
You can ask questions anytime for that one, Cody.
I have all week. I'm curious what you're hearing on your end about reductions in the promised shipment volume of the Pfizer vaccine. I know Pfizer said in a statement last night, millions of doses are sitting in a warehouse without shipment instructions from the government. We know Kansas and Missouri are hearing they'll be getting less than expected. How does this affect you and other health systems? How could it affect you moving forward?
You bet. David, you want to take first crack at that?
Yeah, I wish I had more solid information for you. I mean, we really don't know the reasons for all of this. In sort of planning for the long run, we know that we need an equal number of doses 3 weeks from now for the Pfizer vaccine for those that we receive at the moment. And that is, I'm sure, playing into this to some extent. The other thing is we know that states planned the number of doses that they expected to get based on simulations, actually simulation software that modeled out what it might look like depending on the number of doses available. And that last week, that simulation turned off and the ordering process went into place. And I think maybe there's a chance that some of that decrease is due to sort of what people thought they could get best case scenario in a simulation and what is actually available to be ordered and distributed. But that doesn't answer all of the questions about why there might be doses sitting in a warehouse. As far as what that means for us or our healthcare system, our healthcare workers, or even our patients, is I think it means that the timeline that we had been hopeful that we would be able to achieve for vaccinating all of our healthcare workers and beginning to move right to more at-risk essential employees and at-risk members of the population might be delayed just a touch. And that is not necessarily, or really not in any way, promising news for us. But it's sort of the best answer that I've got at the moment.
Hawkeye, any further thoughts?
No, I think in our initial calls with KDHE, for this initial shipment, we did receive what they had said we would receive. We have talked about this. We are all optimistic and excited about the vaccine. But even before they were distributed, we had seen the stories about the Pfizer maybe not being able to deliver as many as were ordered or promised initially, from the main media outlets. So that was always a concern, not only in the supply and the delivery chain, but moving forward, making sure that everything is going well in the production lines as well. We want as many as we can get, but we know that there can always be slip-ups and reasons that the vaccine or therapeutics or drugs cannot be delivered. This is maybe one of those things. So while we were optimistic, we always understood that those things do happen.
And comment a little bit, just as a follow-up to this, when we're talking about all the vaccine, how much you have, this thing about I got 5 doses, I got 6 doses, I got 7 doses in a vial. What's going on with that?
Yeah, I think it's interesting. It would be very good. So in the vial for Pfizer, it is a multi-dose vial, meaning that you can give 5 doses. So because of the thawing process and the relative little amount of time that you have to use it after thawing, it's important to make sure that you have 5 people that can be vaccinated so none goes to waste. So initially there was supposed to be 5. Some people have said that we are getting 6 or 7 doses out of the vial. I don't know all the details from that, but apparently the FDA regulators are saying it is okay to use it. So they must understand that even in those 6th or 7th dose, you are getting that full 30 micrograms of the vaccine component, because that's the important thing. We want you to get the amount that should be prescribed so that you can mount that response. There's been nothing more than that other than if you can make it work with the volumes that you're supposed to reconstitute, because you do have to add some volume to that vial to get those 5 doses, and you have 6 or 7, that's great. That may give you extra doses, but we need to make sure on the back end, if we were expecting, let's just say, 5 vials to vaccinate 25 people, but we were actually able to vaccinate 30 people, that when we get more vials on the next shipment, that we can vaccinate those extra 5 that got vaccinated the first time. So hopefully that will be consistent throughout the shipments, but we still don't know. And if there is delays in shipping, that could be an issue if you're vaccinating even more than you had anticipated.
All right, other questions from reporters?
Good morning, Taylor, Channel 41. How are you guys this morning?
Hi, Taylor. Are you going to talk about my vest, Taylor? Because you're in good graces if you do.
Well, sadly, I am not. Only because I joined by phone. I'm not watching, so the vest is going to have to remain described to me.
Yeah, check out the highlights.
I have a question about if you can update us on stats that you're seeing and what the numbers tell us about counties and cities with mask mandates versus those that do not. Missouri continues to, and Kansas continue to have multiple counties that do not have mask mandates. Obviously, there's no statewide mandate in Missouri. Can you update us at all on what the numbers say about those that do versus those that don't?
David, have you taken a look at that recently? And I know Donna Ginther was on the program earlier this week and affirmed the data showing even more clear separation.
We continue to see that pattern as far as specifics and how it's impacting hospitalizations. I don't really have a good current analysis, but I think we know that even if a mandate isn't successful in getting every single person in a community to wear their mask, there are some that will do it simply because it is required. And that percentage, when we talk about human behavior, varies, but it's 10 or 20%, right? There's a group that's sort of on the fence, and if we require it, they'll do it, and that is better for us without a doubt. So I think at the end of the day, that rings true no matter what the county is or what the data for that specific county is, that there is a benefit simply by saying you should do this, you must do this, more people will, and that's helpful. So we would expect to continue, I think, to see that impact when there are differences between counties as far as if you have an order or don't have an order, and those that do will have, we would expect for all circumstances, will continue to see lower transmission.
And I think Donna Ginther was on the program again. I know she was on the program earlier this week, and I would refer back to her because I think she affirmed Hawkeye that principle. Yeah. And Amanda, from your standpoint, can you imagine our hospital without a mask mandate internally right now?
Oh, absolutely not. And I imagine, I think back to the kind of vaccine discussion, that what does that mean for our organization whenever we don't have the vaccine available like we were maybe expecting it to be? It really doesn't change anything for us.
Right.
We have to maintain the social distancing, the masking, the good hand hygiene, not coming to work when you're sick, until the vast amount of the community gets their vaccine. It doesn't really change our offensive plan.
All right, that's right. And to point out, are we keeping our employees safe by using good infection control?
Yeah, absolutely. I mean, I think we've continued to demonstrate that we don't see transmission because we have appropriate PPE on, and most importantly, we're wearing the surgical masks.
So I think the mask is the Patrick Mahomes. Oh no, wait, Tyrann Mathieu of the defense.
Honey Badger.
Honey Badger of the defense. I think vaccines are the Patrick Mahomes of the offense. We can have a Super Bowl team, but you got to have both pillars.
That's right.
And both things. But those pillars of infection control continue to matter the most. Other questions?
And if Taylor wants to reach out to me, I'll help connect him for that mask research.
Yep.
Mm-hmm. She did have an update. So
She did have an update. I don't remember it off the top of my head.
I don't either.
It continued to affirm the information, but I don't want to misspeak. She'll have the full information.
right, and I can connect you if you need that help. So, all right.
Thank you.
Yep, you're welcome.
Other questions? Not hearing any. All right, Jill, let's go. We got some.
All right,
we
so
got our
before
core
we do the
questions
first
go.
10, we have two that I think are really interesting. Anil, our long hauler, he
Hi,
wanted
Anil.
to know, do you think that our higher death count is perhaps because we're getting sicker of the sick? Because of
That's a great
transfers,
question.
that they're being more selective?
Oh, that's a great question, Anil. Well done.
He always
David,
has good questions.
He does.
insight.
It is
That
really
is
good
a
insight. And David, we do
insightful
think that's part of our story.
Absolutely, no doubt. We are seeing more patients transferred in needing ICU level of care, and as we sort of identified already, those patients that don't survive are much more likely to be in the ICU. All that being said, if we talk about mortality rates, meaning the percentage of those that hit the hospital, that need hospitalization, that die, there's not actually been a significant increase in mortality rates. It's been relatively flat. The reason there are more deaths is we're seeing more patients. So that really is the driver. Volume, simply the fact that there are more people infected in the community, which means more patients needing to be admitted to the hospital. The percentage of them that need ICU care, that need a ventilator, and that die, those percentages are relatively stable. But when we have a higher number of them, we have more of each of those individual populations.
David, do you think it makes a difference, though, that we're getting more patients who are transferred to us who immediately need to go on ventilators as opposed to other hospitals? So I think, now to your point, though, I think that story's been true all along. There's just more of that story right now, especially coming from rural areas.
Mm-hmm. Yes, I mean, I think we would have to say yes. There is, of course, a little bit of maybe context to understand. The sickest of the sick, I mean, we get calls every day for people who need ECMO or whose ventilatory requirements are so high that it is impossible to transfer them. The sickest of the sick are not actually being transferred in because they're unstable already at that point to come in. But no doubt a higher percentage of those that are hitting our ICU are a higher number of patients hitting our ICU and hitting our hospital in total need ventilation, mechanical ventilatory support, and the mortality rate in that population is higher than even the ICU. So as those people are becoming more frequent, those are a larger portion of the transfers in.
Okay, I'm going to do Liz's before we do our 10.
Go.
She has a situation that I think is a real teachable moment that I hear you guys talk about all the time. Her situation is that her aunt let somebody come to her house and she cut her hair. Next day, the person that she cut her hair tested positive for COVID. In that meantime, the aunt's parents came over. And now everybody is worried, who needs to quarantine? What do we need to do? Who is at risk? And they don't speak to whether they were mask wearing or any of those things. So
Well,
there
it's a
you
little
go.
harder to answer without wearing a mask, Amanda, but you would apply those rules, and if you had it, what would you say?
Absolutely. So the rules that we would evaluate, and again, like getting your county health department involved is going to be important in this situation, but understanding what were the masking behaviors, what kind of contact, and what was the duration of that contact. So were you within 6 feet of another person? Was the duration 10 minutes or longer? Was there active droplets being spewed, loud talking, coughing, sneezing, that sort of thing? I think if there was that extended period of time where they were in close contact, that anyone involved here, once we have the confirmatory test, if you were in that direct contact, I think I'm missing here, the aunt, I think, is the one who got their hair cut by exposed to the positive hairdresser.
Yeah, she was.
So
she was the hairdresser. The aunt's the hairdresser. Somebody came over and got her hair cut at her house.
So the person getting their hair cut was the positive.
Yes.
So the aunt is the one who's been exposed. So she is the one who needs to quarantine. And then if she develops symptoms or if she goes and gets tested and then is positive, then anyone that she was then exposed to would be a close contact.
What about mom and dad dropping by?
Just because they were in close contact with a close contact doesn't mean that they have been exposed. So wouldn't necessarily apply the quarantine rules unless the hair cutting aunt becomes positive, then that definitely changes.
There's a lot of hair cutting in here and a lot of relations.
And it sounds like the parents came over pretty soon after.
Yes.
So was there contact potentially between?
Well, I'm just saying for the hair
person
cutting
couldn't gotten sick
aunt
so fast.
is
Yeah.
probably not
We could call her a
replicating
stylist.
a lot of virus.
To spread.
And
Early
spreading
on
the
in their
virus.
exposure, yeah.
And we know that masks work because we know exactly what happens in this situation if both people wear a mask.
Yeah.
In Springfield.
Springfield.
And all of the patients that they were able to interview out of the 140 from the 2 hairstylists, the ones that they were able to interview, they did not find any direct spread of the disease because both parties were masked.
So if the stylist / aunt, whoever that is, wears a mask, then
Yeah.
everybody can be a whole lot safer.
That's
Okay.
right.
All
Are we
right.
ready to roll on these other
We are.
questions?
Is the health system full? The community rumor is that you are, and that patients are being diverted to other places.
Oh, okay, wow, you're the transfer center guru here, man. I actually think we've been more open than most places.
It might be the ICC thing we talked about.
I know, we're getting there.
Yeah. So the answer to that question is always maybe, because it changes sometimes literally minute by minute. So we may get a call from somewhere that needs to transfer a patient in, and at that moment, every bed is full. And an hour later, we've had 2 patients that have been able to move out of the ICU and things sort of work themselves out. And now we can take a couple of patients. So it's always this hard question, what does "are you full" mean? Are we near capacity? Yes. Have we been near or at capacity every day for the past 2 months? Yes. Maybe minus a few days right there around Thanksgiving where we just had less people showing up to the hospital. Are we transferring patients out only to our own facility in Indian Creek. We are not so full that we are sending patients to other places, but we definitely have found ourselves in the circumstance where we've been unable to accept transfers in from other hospitals who were looking for a place to land a patient who needed a higher level of care.
I mean, there was that Saturday night, oh gosh, it was about 2 weeks ago, where we had 14 requests from the critical access hospitals around El Paso, Texas. We could take 2 of them, we couldn't take 12 of them. And I mean, today our ICU beds are a little better than they had been 2 weeks ago.
They are. We've actually been playing this game, I say it's a game, it's like the shell game, right? We had more need for non-ICU beds the past few days than we did ICU beds. And so some of our units that can be either an ICU or a non-ICU unit, we flipped for a few days this week, and then we're pinging right back up against our ICU capacity and had to decide what to do with those. And so we're actively every day, actually more than every day, several times a day, at least 2 and more like 4 on most days, deciding what do we need to do, where is the best place that we can land patients, and how can we take care of the most possible.
All right.
Okay, I read that antibiotics weaken the immune system. Is it okay to get the vaccine while taking antibiotics?
Hawkeye, I think we're safe on this one.
2 questions or 2 answers for that. Antibiotics do not weaken the immune system. They can certainly, affect other bacteria in your body that are helpful. For instance, bacteria in your gut that help digest food and things of that nature. But antibiotics do not weaken your immune system. You can have the problem if you take too many antibiotics for the wrong conditions or under the wrong criteria, that those bacteria can get resistant to antibiotics, and that is a major problem around the world, multi-drug resistant bacteria. But taking antibiotics will not weaken your immune system. You can take the vaccines if you are ill. This goes with other respiratory viruses. This goes with other bacterial infections. You are able to take that. We would certainly, really the biggest issue is that you really haven't had a fever for 24 hours. But even if you have an active infection, whether that's a urinary tract infection, a separate type of sinusitis or sinus infection, if you're on antibiotics, you are absolutely able to take the vaccine.
We have a long hauler that's asking too if it's okay to take the vaccine because of inflammation.
Well, I think that actually is a good indication to take the vaccine, because you might have been immunocompromised and your immune system may be a little tired by that whole long haul thing. I would say that's actually somebody we'd want to have get the vaccine.
Yeah, absolutely. Getting the vaccine, the guidance from the CDC right now about getting the vaccine in relation to COVID-19 infection is really, it's wanted to hold off because you do mount some immune response with natural infection. So we're wanting to hold off 2 or 3 months and maybe get those people who haven't had exposure to the virus to get them vaccinated, build up some immunity. The other issue is if you are actively sick with COVID-19, they do not want you coming into the clinics or going to healthcare facilities to get the vaccine and potentially exposing others to that illness. But if you look further down in some of the recommendations, even if you're infected, there really is no minimal time from infection to being able to vaccine for the physiologic reasons. It's more for the other reasons of increasing our vaccine supply and also not exposing others if you have active COVID-19 as well.
How is flu season going? Are you seeing less flu since everyone is masking?
Well, Amanda, I'm not seeing a lot of flu so far around here.
No, and we evaluate this every couple of weeks, looking at the regional and national data, and we really haven't seen a lot of flu activity at all, really, in our organization or around the country. And I don't know if you remember the statistics. I know you sent them to me just the other day, but I don't remember the exact volume of tests that have been performed and those that have been positive, so you might be able to add on to that.
It's actually pretty amazing.
Because by now we should see both a lot more numbers in our community and hospitalizations from influenza, because we're in the middle of December. Usually we're dealing with it by now.
And usually the data is about a week behind in the CDC. I haven't looked this week, but certainly last week when we looked at the data from the week ending in November 27th, I believe, there were almost 300,000 influenza tests performed at both clinical labs and public health labs. And they had about 550 or so, just under 600 tests, I think, that were positive. So that's an extremely small number when you think about 300,000 tests being run. And I would even venture to say that some of those positives were maybe the antigen test, which we know can have false positives, especially if there isn't a large prevalence of actual influenza in the community. So very small amounts of flu in the United States in general, and probably in most people's local region as well.
And that's what we saw down in the southern hemisphere, because their flu season was back in July or June, and they really didn't see a lot of influenza there, and I think they attributed it to the same thing.
Yep.
The rules of infection control, what do you know?
That's right. If you're masking, good hand hygiene, not coming around folks whenever you are ill, you're going to prevent the spread. And those are the same things that apply for flu and for COVID-19.
So honey badger of infection control are masks. You know what? They actually work. What do you know about that?
I love that. Is that your name? I'm going to start using that.
No.
all the time.
No, not
Matthew.
her.
Oh, you mean the
Tyra
pillar?
Matthew, he's honey
I
badger.
know
He's the captain of the defense.
I gotcha.
The
I'm with
mask
you
is
now.
the
Come after Amanda.
You have
That
to
would
watch
not
a
be
little more.
pretty.
He
you have
is
to
my
watch more
favorite
football.
player.
Okay.
I know. I like him a lot. I do. Yeah.
Well,
Okay. Question 5. As the vaccine becomes more available, will it change any of the current therapies used to treat COVID-19 patients, like steroids, remdesivir, and convalescent plasma?
Well, we hope it's going to change it, because we hope it's going to need it less often, because people won't be hospitalized because their disease is much milder, and so as a result you won't need these things.
Yeah.
But if you haven't been vaccinated, or despite the vaccine you get really sick, which we haven't actually seen yet, except for one patient in the Pfizer trial, because everybody in the Moderna trial, nobody got that sick once they got the vaccine. So, you would still be able to get those therapies though.
Yeah, so we don't use convalescent plasma. There is enough data out now to support that there really is no benefit of using convalescent plasma. We do have a trial ongoing in collaboration with Vanderbilt University. This is led by Dr. Ella Truni here at the hospital, that we are looking at convalescent plasma for that purpose, but we don't use it routinely for therapy anymore. We still use remdesivir, the steroids, and anticoagulation. And actually what we're hoping is that there are actually more drugs that are going to become available, and we can use them in the outpatient setting. So things like Tamiflu for influenza or Augmentin for other bacterial infections, you can get a prescription and take them as an outpatient to hopefully reduce your amount of viral replication and ultimately decrease the chance of having that severe disease.
And we're
as
not
well.
saying it's actually Tamiflu or Augmentin, but there are drugs that look really good in phase 1 and early phase 2 trials, I think, that are showing some really strong activity against SARS-CoV-2,
Yes.
which would be great, right?
Yeah.
I mean, that is, between vaccination and oral therapy, oh wait, we can make this as bad.
Yeah.
We can actually make this feel like influenza instead of having people say it's the same as influenza, which is deadly wrong.
And we also have that monoclonal antibody that there is more data now suggesting that it is extremely or very effective, 70% or more, in reducing hospitalization for those high-risk people who are at risk for hospitalization.
Yeah, so if you have any questions about that and you think you might qualify, just call us, because we'll step through that whole that whole algorithm with you, because we've been using the monoclonal antibody, and I think we're pretty pleased with the effects so far.
Absolutely. And I think it's important to note that the effectiveness of it, and if you do meet the criteria, to get in touch with us, because I know that's a message that we need to get out there, is that it's available.
Strict criteria, but we also are actively screening patients. So we have a protocol and a system here to actively screen our positive patients as well.
And I think it's, again, really important. We talk a lot about vaccine, but in all that discussion, the monoclonal antibody therapy has been kind of lost a little bit, but the reality is it is good stuff, and I think we ought to try and make sure we get to
And I would just like to point out too, from some of our other threads and listservs and information we get over the email, I think we're doing a very good job here. A lot of health systems or hospitals are having a hard time doing it because of the systems needed. And that is actively screening patients. That's having places where you can actually infuse when you know you're bringing infected patients into these areas. So I think we've done a pretty good job here of that.
Yeah, and just to say, the trick here is the active infusion, because active infusion therapy, we have to come into a hospital setting or a IV setting to get IV therapy. you have to actually have the right teams around, you have to have vacancies, and in this case, you have to separate out the COVID-19 patients, because you don't want those patients in the same bay next to somebody who doesn't have COVID-19. So we've really had to create a whole ward for doing that around our doing that around our infusion center, and then you have to staff that. And as people are sick, the staffing's reduced, so it's a little bit of a trick to run. A lot of places haven't elected to do that, and I think so. Just if you're sick and you're one of our patients, make sure you give us a call, because we want to talk to you about it.
Next question is about Moderna vaccine. A lot of people want to know, is it going to roll out faster than Pfizer because it has to be kept less cold? And they also want to know about side effects. They're reading that they're worse. Can you define what worse is?
We'll talk about that. I'm not sure about that side effect statement. You and I are going to have a conversation about this. I'm not sure that's entirely accurate. David, what do you think about its rollout and the production of the Moderna vaccine, which we hear is going to be faster than the Pfizer vaccine? And then is it better and easier to distribute?
Well, no doubt the distribution logistics are easier when you don't need ultra cold chain storage. And so that's just a fancy way of saying the temperature that is needed for safe transportation and distribution is not nearly as cold as the Pfizer vaccine. It also comes in a slightly different configuration for the number of vials per carton, which means the number of doses per carton. It's a little bit easier to distribute in smaller numbers and longer distances. So I think there will be some benefit there, no doubt, in using the Moderna vaccine to get to more rural communities, to smaller hospitals that may not be able to administer a large number of the Pfizer vaccine, for example, in a short period of time because of the logistics or the number of patients in their community. So all those things will come into play. It's I think we talked about this earlier in the week or last week. It's nice to have a menu of options, whether it's a menu because one vaccine has some characteristics that are better or easier around logistics, or because one vaccine has some characteristics that are better, say, for an elderly population. So I think those things will play out over time. Whether or not the actual manufacturing process will be faster and easier, I think I'd say the jury's still out there.
Yeah, I think we're contracted for more Moderna vaccine than we are Pfizer vaccine at a federal level, so that will help increase the supply of that vaccine.
Yes.
Talk to us a little bit about that side effect point, because when I looked through it, I thought that the side effects really looked pretty similar overall.
Yeah, they were both I would agree with you. So very similar with, the biggest side effect that most of the people had, and it was up to 85 or 90% of people who got the vaccine, was the site reaction, so where the injection is given, and that was pain or discomfort. And it's hard to tell because in Moderna they said grade 3, in the Pfizer they said mild to moderate. Essentially what that is do you need to take pain medicine to help? Does it affect your daily?
And that means Tylenol.
Tylenol, yeah,
right.
Sorry. Tylenol to help with the pain, and does it affect your daily life? And really all of those were similar. The side effect profile for fever and headache and fatigue, which are the other top 3 side effects, were very similar between those. And also, they increased a little bit with that second dose as well. So overall, they were very similar side effect profiles.
Yeah, and just to say, there was also a couple articles that came out yesterday in the New England Journal looking at immunogenicity, that is how strongly we respond in our immune system to a vaccine. They looked at it for those who are older, and they looked at the Moderna vaccine, and then they actually looked at the Pfizer vaccine, but there are 2 different vaccines they tested, one against what's called the receptor binding region, and one's against the whole spike protein. And so let's talk through that a little bit, because I think what it demonstrated is that even as you get older, you still get good immunogenicity to the Moderna vaccine, and secondarily that there may be some new developments with the Pfizer vaccine. So thoughts about those?
Yeah, I think it's nothing other than what you had said over that. But I think one point to bring up too is that as we're looking at older patients as well getting the vaccine, and you had brought this up before, those amount of side effects were decreased to the population compared to the younger people as well. So that's a good thing.
And Amanda, we've been giving the vaccine now here for a couple of days. Any surprises there?
No, I've contacted a few folks that have had the vaccine, and they're feeling good. So I think that's really really more of that ray of hope that we're seeing, is that we're not, we are prepared if we have staff that do have that inflammatory response and don't feel well enough to come to work. But I don't think we've had to employ that plan quite yet.
Yeah, it's great news. So it's going well. They're not collapsing, they're not having anaphylaxis, and they're not having terrible pain.
That's right.
I heard the Pfizer vaccine could give you facial paralysis. Is that true? And if yes, is it permanent?
Okay, this is Horner syndrome that they're talking about, Hawkeye, I think, and you want to comment on that?
Horner's and Bell's palsy.
And Bell's palsy, yep.
Yeah,
yep.
I got a question from...
Actually, Bell's palsy, not Horner's, my bad. Go ahead.
From Dr. Doolittle yesterday about a patient. Dr. Doolittle is one of our oncologists. Yeah, I think there were 4 cases of Bell's palsy in the vaccine group versus the placebo group. But in those cases, there was no causality determined. So that means that they did not find that the vaccine itself caused the Bell's palsy. So I think it's still safe, and your risk of getting Bell's palsy or that facial paralysis is just greater being out in society than it is getting the vaccine.
Yeah, so I think that, any virus that we know is associated with Bell's palsy, and it's kind of a droopiness of one eyelid and one side of your face and a little loss of sensation, and most of those resolve over time.
Yep.
It is transient. A few people can be maintained lifelong. And so that probably is something we'll have to follow up on. However, just to say that there are many causes of Bell's palsy, and immediately go and say, well, it was the vaccine that did it. Yep. It's hard to know. And so far what they've concluded is that is not a true statement, that was not caused by the vaccine. And when the numbers are low like that, like 4 or 2, you have to be very careful drawing a lot of conclusions from it. So I think it's going to end up being safe. I'm not sure that that's going to be a concern. I actually think the anaphylaxis stuff is not going to be a long-term concern either, and especially because we have immediate therapy for that. Remember this as you consider vaccination. Here's the risk of death from COVID. Here's the risk of death from vaccine. It is not comparable. Remember that we have studied 80,000 patients with either Moderna or the Pfizer vaccine, and if you throw in the AstraZeneca trial and others, we're well over 100,000. There have not been deaths in the treatment arms from the vaccine. And so, but there have been deaths in the people who didn't get the vaccine, quite a few deaths. And so I think you just have to sit back and look at the real data. Don't look at internet data. Internet data, bad news, because people like to prey on folks. But look at the real data. Look at the stuff that's coming out of the New England Journal and the CDC guidance and the stuff that's being published.
I have one comment about that. Casey Pickering, one of our nurse managers here, was one of our first 5 that received the vaccine, and they mentioned the fear of getting COVID over the fear of getting the vaccine, and I think that is just a really a testament to the value of the vaccine.
Yeah, that's a great point. Casey's great.
The next question is about COVID, not the vaccine. And the question is, what do you know about the study showing athletes who had COVID-19 are now having heart issues? How permanent and dangerous is that damage?
We know that that's a concern, Hawk, and we've seen some patients like that. You and I have had discussions, and David has been involved with us about things for different athletics and things we've worked on with the Big 12 and KU. What are your current thoughts?
Yeah, I'd like to throw that answer to David first, because we actually have active conversations about this almost on a daily basis. So I think he's probably good to answer that one as well. We are very concerned about it.
You're right, Dana. There is a group of us that is constantly monitoring what we see come in the sense of anecdotal reports and also in the study, the literature. This question about heart involvement and heart involvement in athletes, I think, is interesting because it's not necessarily that athletes are at a higher risk. In fact, it's not that at all. It simply is we know that people have differing inflammatory responses to being infected with the SARS-CoV-2 virus and having COVID-19 disease. And in some people, that inflammatory process attacks the heart. That's not unique to this virus. It's actually a common set of circumstances in that many viruses can cause it, but it's always in a small subset of the people who are infected. What we're hearing now, though, is that there are groups, for example, where a large portion of a specific team may have been positive earlier in the year, and stories very recently where an individual athlete has a reaction, a health issue on the field or on the court or off that requires them to get testing to see if their heart is involved and if their heart function is okay. And those stories are becoming more common as the infection becomes more common. And so I'm not surprised by that. I think it's balanced. I know this is blending two questions here a little bit, but we're seeing the same thing in children. So I think all of us, Steve, Dana, and I were all on a call earlier in the week where our colleagues at Children's Mercy told us that their incidence, the number of cases they have seen of severe inflammatory reactions weeks to months after COVID infection in children, that's called multi-system inflammatory syndrome in children, that they have seen more in the last month than they had seen in the entire 9 preceding months. So these things will be more prevalent, more frequent, not because the disease is getting worse, but because more people are being infected.
Yeah, I think that's exactly right. And Joe, maybe one of our future programs, we need to get our colleagues from Children's back on to talk about some of these issues
Actually,
that are cropping
they're
up.
on next week, I believe.
Oh, there you go. See, that's
See,
perfect.
Yeah, I listen to you every day when you leave and you give me ideas.
Here's
so
another idea.
I
Watch
can
out for
take
that.
direction.
All right.
Okay, question 9. A Mayo Clinic study shows masks prevent droplets at 3 feet and is the most important thing to protect against the virus. So why do I need to stand 6 feet away? And do I still need to wash my hands and surfaces and food containers?
All right, Amanda, take it on. Let's
I
go.
think we have seen the evidence that the farther away, the likelihood of those droplets coming into contact with you it lessens. So 3 feet, 6 feet, 9 feet, 12 feet, the farther away that you can be, the better. Masking obviously keeps them closer to you than to other people. Hand hygiene is always going to be the pillar of infection prevention, so it's always good, not just in the midst of COVID-19. Environmental disinfection, so removing that the germs off of surfaces that are frequently touched. Those basic principles, just we do need to continue to do those things. Absolutely.
And the thought about 3 feet versus 6 feet,
Yeah.
because when we were doing our time in the freezer, 6 feet. I
Yeah.
mean, but the droplets aren't as concentrated at 6 feet as they are at 3 feet. And
Yeah.
the World Health Organization has long said 3 feet.
Yeah, absolutely. As of earlier this week, that was unpublished data put out in a press release. Just to your point, the World Health Organization has said 3 feet. That's because there's a lot of populations around the world where it's difficult to maintain 6 feet apart. The United States, the CDC, has said 6 feet, but they also say 8 feet is better, 10 feet is better, just because of what you said. Different droplet sizes, especially if you're doing things in large groups and gatherings and you're talking, laughing, yelling, cheering, things of that nature, you can have spread further. So the distance and the masking, the barrier protection that the masking provides are those two main pillars. Those are what is going to help.
All right, last question. I am 48 and healthy. My mother and aunt are in their 70s and have numerous comorbidities. If they take the vaccine, why do I need to take the vaccine?
Oh, somebody who does want the vaccine. Okay, let's all three take us. All three. There's 4 of us. I can do math.
I think we are all in this together. I think the only way that we're going to defeat this is if we're all getting vaccinated together. That's part of building the herd immunity concept. So healthy or not, we all need it if we want to return to any sense of normalcy.
Dr. Wild.
Yeah, I agree with Amanda. While you may have the perspective here that you're aiming to protect your family members, getting vaccinated protects everyone in your bubble, everyone that you come in contact with. And we need that sort of protection to prevent spread to, say, your neighbor who may then come in contact with their family who's older and not yet vaccinated. So preventing spread, that's the goal, and it takes everyone.
Okay.
Yeah, absolutely. I mean, we've maybe seen some signal that people who get the vaccine are also less able to transmit the disease because they have less viral replication and high viral titers, but that has not been proven yet. So we want you to stay well from getting the vaccine and getting immunity to protect yourself against severe and critical disease, but we also want to make sure that you are able to stop spreading the disease. So that is why vaccination for everybody is important, as well as maintaining that masking and distancing, because even those people who you have discussed and talked about getting the vaccine, they still may be able to transmit it at the same level or less level or not at all. We just don't know that yet.
Well said, team. So Next week is Christmas week. And that's a big deal, right? After all, I wore a nice and cool Christmas vest today. So we have a really great lineup. It's going to start with Dr. Jessica Calendar-Rich. You know, CVS and Walgreens began its partnership to vaccinate staff and residents in nursing homes. By the way, when CVS and Walgreens can play together, that's like the Chiefs and the Raiders playing together. Dr. Jessica Calendar-Rich is a national member of the Coronavirus Commission for Safety and Quality in Nursing Homes and practices general and geriatric medicine. She has much to update us on about seniors, COVID-19, the status of vaccination of seniors, because we know that's going to be a game changer. So, you know, as we approach Christmas week, a few thoughts. For my family, it's going to be much smaller gatherings than we normally have. And so it's going to be a little bit of a quieter Christmas. And my mother-in-law, who I've promised never to say on this air again that she's 88, oh, wait a minute,
Right.
is at Bishop Spencer Place. Well, they've done a great job of taking care of their folks in independent living. But we'll still see her through Zoom, and we may stand outside her balcony, masks on, trying to sing to her, which may not be good. Actually, that may be terrible. We may not try to sing, but we'll try. But as we approach these holidays, even though Christmas may be a little softer, and holiday cheer may be a little quieter, remember that the spirit of Christmas isn't about a lot of gifts, and it isn't about a lot of cheer. It's actually about a very simple gift. The greatest gift we can give to each other this Christmas is to keep each other safe. And we know how to do that. Because while vaccines are still coming, the things that keep us safe, keep our hospitals safe every day, and keep you safe whenever you come here, are masking, keeping our distance, washing our hands, controlling the spread of this infection. It's still a great defense. And it's what's going to keep us safe this holiday season. We'll be back next week. Remember, the simple gifts are sometimes the best. We'll see you soon.